Welcome. I'm Jose Garcia, CHIA President, and I am thrilled to be here today moderating today's event. Title VI for Medical Interpreters, Supporting Language Access and Federal Compliance. It's one of the primary language accommodation mandates with which healthcare organizations must comply in order to reduce liability and improve patient care. It is critical, therefore, for medical interpreters and managers of interpreter agencies, departments, to understand how to support compliance. This presentation breaks down the various components of Title VI as it applies to medical interpreters and healthcare language access. The concepts of covered entity, federal financial assistance, and LEP will be discussed in detail. Policies and procedures specific to interpreting is covered, including staffing, interpreter competence, and the use of family, friends to interpret. In addition, we will touch on other tenets of Title VI compliance, translation of written materials, providing notice to LEP person, staff training, program monitoring, and the compliance process. Our presenter today, Michelle Scott, is a bilingual RN and founder of Voices for Health. Her experience includes medical interpreting, translation project management, interpreter training, curriculum development, research projects, and film production. Her bachelor's degrees in Spanish and nursing and master's degree in medical anthropology were earned at the Michigan State University. As a nurse, she supervised a migrant clinic coordinating migrant camp outreach programs and provided maternal support services. Currently, she is the administrator for VoicesAcademy.com, a virtual conference website providing instant access to continuing education interpreters, and she joined the CHIA board in 2015. Please join me in welcoming and thanking Michelle Scott for hosting and presenting today's webinar. Michelle?
Thank you, Jose. Good morning, everyone. As Jose mentioned, we're very excited to be offering this first of a series of monthly webinars for CHIA. So we're excited to have people both from California and from other parts of the country joining us. And just to say that that's one of the exciting things about offering the webinars is we, as an organization, have been providing on-site trainings regularly for a very long time, but we're excited to be able to reach out and provide training to interpreters across the country now, right, Jose?
Can you hear me?
Yes.
That is true, what you just said. Over the last several years, CHIA as an association has focused on interpreter training. And for a long time, we launched the webinar program and series, and we are very, very happy and excited that we finally are able to do that. So this is the beginning of hopefully a very long series that we can maintain and reaching out a lot more interpreters throughout the country, not just on site to a limited number of interpreters.
Exactly. So yes, so thank you again to everyone who's joining us. And we chose this topic today because we feel it's an important topic from a theoretical perspective for interpreters to understand, as well as interpreting managers. Title VI has been around for a while, but it's not always something that gets talked about in interpreting circles. So I'm very excited to present this topic to all of you, and it's one of the topics that I'm passionate about. So I'm going to go ahead and jump in. I want to let everybody know as well that you've got a little dashboard with your GoToWebinar panel, and you can feel free to type questions in at any time. We will have a question and answer session at the end, so I'm going to be presenting for about an hour, and then we'll take about 15 to 20 minutes to answer questions at the end. based on the content of the presentation. So the first thing I want to mention about Title VI is that the Office of Civil Rights does not endorse any educational programs about Title VI. They are aware, however, of this particular program. I've been working for about 15 years to educate clients about Title VI. I've had personal meetings with OCR representatives, many phone calls, and a lot of client feedback. So that's the basis of much of the information that I'm going to be providing you with today, as well as real-world examples from working with healthcare providers and their types of questions and the types of responses that that I tend to work with. So one thing, though, again, about the Office of Civil Rights, so having said that I've had personal meetings with them and presentations with them, they are wonderful about providing technical assistance to any healthcare organization that wants to ensure that they're operating an effective language assistance program. So this, again, is an introduction, but if you have detailed questions specific to your organization, I really encourage you to contact OCR, and they have regional representatives, and these are some of the nicest people that I've had the pleasure of talking to about language access and language compliance, because they really understand the issues. They're passionate about it. They really want for LEPs to, for limited English proficient patients, to have access to equal healthcare services. So, and as far as this goes for interpreters, I want you to keep in mind that this is part of your advocacy role. I consider every encounter with a patient or a provider to be an opportunity for education. So in this opportunity, by understanding Title VI, you can hopefully shed some light to both patients and providers about what this means, what people's responsibilities are, what people's rights are, and just to feel more comfortable with it yourself as far as being able to explain it. So let's go back in history a little bit. This is part of the reason that we have a Civil Rights Act. These are the kinds of signs that used to be posted around this country, and they were clearly very discriminatory. And this was some of the impetus for the Civil Rights Movement. So some of you, again, you may have seen these, and if you didn't, I know there's probably many people on our call today that are from other countries and have not seen these signs or don't know what this history is about and don't understand what some of the segregation and discrimination was like, perhaps 50 years ago in this country prior to the Civil Rights Act. So in July of 1964, Lyndon B. Johnson signed the Civil Rights Act. Quite simple. But it didn't have a whole lot to do with health care and language access rights until August 11th of 2000, when President Clinton signed an executive order. It was number 13166, which was called Improving Access to Services for Persons with LEP, Limited English Proficiency. So the two major initiatives of this were to, number one, better enforce and implement an existing federal obligation under Title VI of the Civil Rights Act of 1964, including to individuals with limited English proficiency. And the second was to meet the same standards as federal financial assistance recipients in providing meaningful language access to federally funded programs and services. So to explain in very simple terms, the Civil Rights Act, Title VI of the Civil Rights Act, has been around since 1964. It was around for nearly 40 years before it started to be enforced and started to be applied to language access and not only in healthcare actually, but also in other areas such as education and the judicial system. So This has been around now. This has been getting implemented for nearly 15 years, but we're still in the beginning phases for much of the country. Many healthcare organizations still don't quite know what Title VI is. Providers maybe haven't heard of it, although we have seen a paradigm shift, and certainly there are more people that know what it is. There's still a lot who don't, or who don't understand it well, or who simply don't comply. In 2009 and 2010, President Obama expressed resolve to address unmet language access needs and requested federal agencies to recommit by undertaking action. The U.S. Attorney General provided implementation guidance through the Department of Justice, Civil Rights Division's Federal Coordination and Review section. So that office was designated to assist agency plan development as needed and to receive revised plans in 2011. So basically what President Clinton did in 2000, President Obama came by and said, okay, let's really recommit to this and make sure that individuals have meaningful access. So what actually does Title VI say? Title VI says that no person in the United States shall, on the ground of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any federal program or activity receiving federal financial assistance. This is the actual language. So this language basically prohibits intentional discrimination and policies and practices that might appear to be neutral, but which have a discriminatory effect. So let's look at the language a little bit. It's that I had highlighted, as you see, I'll go back to this slide just a moment. I've highlighted some things in blue, and those are some of the bits of language that I'm going to examine now, and we're going to go into some detail about. So no person, it doesn't say no citizen, no man, no woman, no child, no Christian, no wealthy person, no educated person, no insured person, no English-speaking person. It just says no person. So it doesn't matter if we like the person, if we like the patient. It doesn't matter if we like the social group he or she represents. This is all-inclusive. Also, national origin. It doesn't matter if somebody is a naturalized citizen, a resident, a refugee, an undocumented immigrant. It doesn't matter. National origin does not look at somebody's status as far as being in the United States. It goes further to say that no person shall be, quote, excluded from participation, denied benefits, or subjected to discrimination. So basically what it's saying there is that you cannot make some services available to certain people and not available to others. So who does this apply to? It applies to what are called covered entities. All entities that receive federal financial assistance from Health and Human Services, either directly or indirectly through a grant, contract, or a subcontract. The covered entities include any state or local agency, private institution or organization, or any public or private individual that operates, approves, or engages in health or social service programs and activities that receive federal financial assistance from HHS, which is Health and Human Services, directly or through another recipient or covered entity. So, what are examples of this? Medicaid, Medicare, WIC, research grants. There are many examples of federal financial assistance, but again, it means that it's direct or indirect assistance. So covered entity, that can be a large or a small organization. It can include, but it's not limited to, hospitals, nursing homes, home health agencies, managed care organizations, universities, and other entities with health or social service research programs, state, county, and local health agencies, state Medicaid agencies, state, county, and local welfare agencies, programs for families, youth, and children, Head Start programs, public and private contractors, subcontractors and vendors, physicians, and other providers who receive federal financial assistance from Health and Human Services. So what is federal financial assistance? It includes, but it's not limited to, grants and loans of federal funds, grants or donations of federal property, details of federal personnel, or any agreement, arrangement, or other contract which has one of its purposes the provision of assistance. So for example, hospitals typically are receiving federal financial assistance. They receive Medicare, for example. They're Medicare providers. A hospital can therefore require that a doctor who has contracted privileges provide language assistance. So in other words, if, for example, the doctor does not accept Medicaid or Medicare, for example, they're not receiving in any way any federal financial assistance, the hospital that they contract with can still require them to provide language assistance. Title VI, it defines limited English proficient as the following. An LEP is an individual who cannot speak, read, write, or understand the English language at a level that permits him or her to interact effectively with healthcare providers and social service agencies. Notice this does not say non-English speaking. It says limited English speaking. So what if, for example, the patient speaks English but does not read it? What if they can understand and even have a conversation, but they don't have a good comfort with medical language, medical terminology? Or perhaps they're simply stressed out and sick and they're not thinking well in English. This is why it says limited English proficient. The key here is that the patient decides whether or not they need assistance. It is not the right of the provider to determine whether or not the patient needs an interpreter, for example. It is the patient's choice. And I like this little slide here. We don't speak English, but we promise not to laugh at your Spanish. So I think a lot of people might feel that way. So how do people gain meaningful access? Well, they don't need any elven magic or code words. Nothing like that is necessary. The basic requirement is that in order to ensure compliance with Title VI, the recipient or covered entities must take steps to ensure the LEP persons who are eligible for their programs or services have meaningful access to the health and social service benefits that they provide. That is direct language from OCR. So the most important step in meeting the obligation is for recipients to provide language assistance that's necessary to ensure such access at no cost to the LEP patient. This is very important. Many providers want to comply, but they want to charge the patient for the interpreting services, for example. This is not allowed. This is a non-reimbursed mandate. Some states are working towards reimbursement, and this is actually one of the things that was an impetus for national certification. So prior to the International Medical Interpreters Association, the IMIA, becoming the IMIA, they were the Massachusetts Medical Interpreters Association, the MMIA, and that was one of the organizations that was instrumental in starting to push toward reimbursement of interpreting services. And what was happening at the time, this was a good 15 years ago or so, was that their legislature in Massachusetts said, you know, that's understandable. We can see why you would want to have reimbursement, why you need reimbursement for this mandate. However, we need to see that people are qualified. If you're going to have interpreters and you're going to receive reimbursement for this service, we need to see that individuals are qualified in providing the service. So as we all know, there's, a dilemma sometimes when we're talking about what qualification means. So therefore, it became very important to have a certification process. And again, this was one of the things that started leading toward national certification of medical interpreters. So the key to providing meaningful access for LEP persons is to ensure that the recipient or the covered entity and the LEP person can communicate effectively. The steps that are taken by the covered entity must ensure that the LEP person is given adequate information, is able to understand the services and benefits available, and is able to receive the services for which he or she is eligible. The covered entity must also ensure that the LEP person can effectively communicate the relevant circumstances of his or her situation to the provider. Okay, so let me review that again. They have to be given adequate information. They need to be able to understand the services and benefits. They need to receive those services and benefits. And not only must they understand what the provider is saying, they have to be able to communicate what their issues are to the provider. So the communication has to go both ways. So what requirements must an organization fulfill? The policies and procedures to assure appropriate language access include the following 5 components. Number 1, oral language interpreting. Number 2, translation of written materials. Number 3, providing notice to the LEP persons of the right to language assistance free of charge. Number 4, staff training. And number 5, program monitoring. And it's pretty much in that order that OCR is going to be looking at compliance. So they're going to, those are sort of in order of importance: interpreting, translation, providing notice, staff training, and program monitoring, although they're very much interrelated. So oral language interpreting, what does this mean? The options, you have different options. You can hire, and this is according to the Office of Civil Rights. Office of Civil Rights understands that this can be a tricky mandate to comply with. They understand the dilemmas in providing language assistance to a very wide range of individuals speaking many, many different languages, hundreds of different languages in this country. They understand that there are the common languages and the languages of limited diffusion. They understand that this mandate must be complied with whether you're in an urban setting or a rural setting. So in order to do that, in order to allow for the broadest range of possibilities for compliance, they acknowledge that there's different ways that interpreting can be provided. So here are some of the options. Number 1 is to hire bilingual staff who are trained and who demonstrate competence as interpreters. Another is to hire staff interpreters who are competent and readily available. A third is to contract with interpreters who are competent and readily available. Fourth, to utilize volunteers who are competent as interpreters, are readily available, and maintain client confidentiality. And then lastly is to utilize a telephone or a video interpreting service as necessary. So one of the things, as I mentioned, those 5 things about those 5 options that Office of Civil Rights provides, notice that in every single one of those, they indicate that the interpreters must be competent, whether they are staff, whether they are contract, whether they are volunteers. One of the key components is that those individuals must be competent as interpreters. And they also mention readily available. They mention using phone and video as necessary. I know a lot of organizations use that as their primary means of interpreting. I don't think that OCR would have issue with that as long as the service is available. And again, that is the main thing. So when talking to Office of Civil Rights, typically what they say is that if you have staff or on-site interpreters in some capacity, that's great. However, what do you do when those individuals are not available? They expect you to have a backup plan. They expect you to have a backup plan as a telephone or a video service for when those on-site interpreters are not available. So the competency of interpreters does not necessarily mean that they need formal certification as an interpreter. On the other hand, competency requires more than self-identification as bilingual. OCR is very clear on this. The competency requirement contemplates demonstrated proficiency in both English and the other language, orientation and training that includes the skills and ethics of interpreting, fundamental knowledge in both languages of any specialized terms or concepts, sensitivity to the LEP person's culture, and a demonstrated ability to convey information accurately in both languages. What I love about this is that this is an excellent description of what we do as interpreters. So they really have it down. They have a very clear understanding of what interpreters do, what they need to do, what the skills need to be. What about the use of family or friends as interpreters? OCR is very clear that a recipient or a covered entity may expose itself to liability under Title VI if it requires, suggests, or encourages an LEP person to use friends, minor children, or family members as interpreters, as this could compromise the effectiveness of the service. Why is this? Use of such individuals can result, number one, in a breach of confidentiality, or in reluctance on the part of the individuals to reveal their personal information that could be critical to their situations. If an LEP person declines the right to free interpreter services, the recipient or the covered entity, in other words, the healthcare provider, may use the family or friend if such use of that person is not going to compromise the effectiveness of the services or violate the LEP person's confidentiality. That's a little bit tricky, but it is acknowledged that that can happen. OCR, in other words, acknowledges that that possibility could exist, although they discourage it. If this situation arises, it's important that the healthcare provider document the offer and that the patient declined the interpreter. They have to put that in the LEP patient's file. And even if an LEP patient chooses to use a family member or a friend as an interpreter, the healthcare provider can still has the right to have a trained, qualified, competent interpreter sitting in on the encounter to ensure accurate interpreting on their end. So let's move on to written materials. Translation of written materials. It's important to ensure that the person translating materials is well qualified, and the Office of Civil Rights will consider that a recipient or a covered entity is in compliance with Title VI, the Title VI obligation for translation if, and this gets into technical details, and some of you have asked me if resources are going to be made available for this information, and I will be providing websites, yes, at the end. My last slide is the websites to point you to the Office of Civil Rights, where you can find all of this information. I also have a nice little 2-page primer available if anybody's interested in it, and I'm happy to provide that to anyone. And it contains this exact language. So basically, compliance means that if you have translation of vital documents, which would be, for example, consent forms or, let's say, discharge instructions, provided for each eligible LEP language group that constitutes 10% or 3,000, whichever is less, of the population of persons eligible to be served or likely to be affected by the recipient or the covered entities program. Now, I know that sounds technical, and I know you might be writing that down or trying to keep track of that. But basically what it's saying is that vital documents are the priority. For LEP groups that don't fall into that, so in other words, they are 5% or 1,000 of the population of persons that are eligible to be served, you have to assure that at a minimum the vital documents are translated into languages. So in other words, depending on the percentage of the patient population, the demographics, that is going to determine the types of documents that you need to have translated and really what OCR is going to be looking at as far as compliance. And so what they're saying is that other documents can be translated as needed if you have a smaller population sample for a particular language group, and that if needed, the translation can be provided orally, which by that, of course, they mean sight translation. And if you have individuals that fall into language groups that are fewer than 100 persons in a particular language group that could be served by your program, they don't necessarily require written translation, but they do require sight translation, and they are very clear that it has to be competent oral translation. So in other words, an interpreter that is competent in sight translation. So how do you know whether you've got your 10% or your 5% or your 3,000 or your 1,000, and what your threshold is for these languages? There's a lot of different ways to determine this. It doesn't matter how many people you have walking in the door that speak a particular language, and this is an important point. What matters is how many people have the potential to be served in a particular language group. So for example, I've had people say, well, we only have a couple of Spanish speakers in our clinic, so we don't need interpreting services. But if the population of this city in which a clinic is located has 13% Spanish speakers, then that clinic really needs to have interpreting services available. Otherwise, they may not be providing meaningful access to those individuals who could come to access those healthcare services. So how do you get to determine that information? You can use census data. A lot of organizations use school data, school language data. You can use refugee data, surveys, or collecting language spoken at access points within the organization. My personal recommendation is to use a combination of these. Again, vital documents is the key for OCR as to what you want to make sure that you have translated, and that could be, for example, anything that requires a signature. So if it's a consent form or discharge instructions, that's pretty clear that those are vital documents. Now, one question that I will throw out there for you to ponder is, although OCR acknowledges and allows for sight translation in order to be in compliance, we have to think about what our interpreting ethics and standards say about translation. Sight translation, excuse me. So think about that and think about what it means to be competent in sight translation, because that's, again, key. So the third tenet is providing notice to LEP persons. So methods of doing that are not limited to these possibilities, but these are some of the ideas that you can use. You can have language identification cards, which are often called I speak cards. You can use posting signs at points of entry that inform the LEP individuals of their right to free language assistance programs. You can have translation of application forms and instructional, informational, and other written materials into the non-English languages, again, by competent translators. And then having uniform procedures for timely and effective telephone communication between staff and LEP individuals. So I'll give an example of that in a moment. And then inclusion of statements about the available services and the right to free language assistance provided in any materials that might routinely be disseminated to the public. So for example, a website would be a good place to put that. Any brochures that would be put out to the public, you would want to include that you've got these language services available. An example of uniform procedures for timely and effective telephone communication, one thing that comes to mind among some of our clients is the private practices that have after-hours on-call physicians. So how is it that an individual is going to know that if they call after hours that they're going to have access to, for example, a telephone interpreter when their provider calls them back? So that's an example of where you'd want to have a procedure and have something in place where individuals would know that not only are they getting language assistance when they're on site, but also when they are calling into an organization. So what about staff training? Staff training. Effective training ensures that employees are knowledgeable and aware of LEP policies and procedures, are trained to work effectively with in-person and telephone interpreters, and understand the dynamics of interpreting between clients, providers, and interpreters. So in other words, staff need to know what to do and how to do it. It doesn't make any sense, and it's not good enough to contract with language services or to have interpreters on staff if the frontline staff, if the clinical staff don't know how to access it or don't know how to effectively utilize the interpreters. Program monitoring. So program monitoring is crucial for a recipient or a covered entity to monitor the language assistance program at least annually in order to assess the current LEP makeup of its service area, the current communication needs of LEP applicants and clients, whether their existing assistance is meeting the needs of these individuals, the patients, whether the staff is knowledgeable about policies and procedures and how to implement them, and whether sources of and arrangements for assistance are still current and viable. Now, OCR, like I said, they would like to see this happen annually. What I tend to see is that people look at these things once every 3 years in a panic when the Joint Commission is coming to do their recertification. So ideally, you're going to be doing this much more often. Ideally, the organization is going to be doing this more often. But if Joint Commission is your motivation and that will get you to take a look at some of these access issues, then so be it. At least it's happening, and that will help to fulfill your compliance requirements. And I'll read this slide here, which I think is amusing. So, he's saying a quantitative study, no way, too expensive, takes too long. Focus groups, nope, too easily swayed by strong personalities. Well, fine, what then? Well, monitoring social media chatter and cherry picking quotes that we like. That clearly is not the way to do your assessment. So how does this get enforced? How do we know if somebody is in compliance or not? Who is paying attention? Compliance is a complaint-driven review process. And the complaint would be taken to the Office for Civil Rights. It must be made in writing, and anyone can make a complaint. So in other words, it doesn't have to be the patient that's making the complaint. If somebody works for let's say a refugee organization or some sort of a service organization, and they learned that a patient didn't have access to services, let's say they went to the emergency room and another patient was interpreting for them, that individual could be a social worker, could be a friend, could be a school principal, it doesn't really matter. Any of those individuals can make a complaint on behalf of a patient to the Office of Civil Rights. So what happens then when the OCR does that? They will assess compliance on a case-by-case basis, and they will take into account the size of the recipient or covered entity. So in other words, they'll take into account the size of the healthcare organization, the size of the eligible LEP population that the organization serves, the nature of the program or the service, the objectives of the program, the total resources available to the organization, in other words, the recipient or the covered entity, the frequency with which languages are encountered, and the frequency with which LEP persons come into contact with the program. So you can see there's a lot of considerations that they have. And let me be clear, Office of Civil Rights would much rather talk with you and talk with your organization about language access and how you can assure meaningful access based on your parameters, based on all of these considerations, instead of receiving a complaint after. So again, if you have any questions, their contact information will be at the end, and that's the best thing to do, is to get in touch with them so that you know exactly what the limits and expectations will be. Office of Civil Rights will review the totality of all of these circumstances for each case. So it doesn't mean that if you have failure to implement one of those elements that you're in non-compliance. It doesn't necessarily mean that. They're going to look at all of these different factors. Also, they're clear that if implementation of one or more of these options is so financially burdensome as to defeat the legitimate objectives of a program, or if there are equally effective alternatives for ensuring that LEP persons have meaningful access to programs or services, Office of Civil Rights will not find that the recipient or the covered entity is in non-compliance. Keep in mind that this sounds very nice and very promising. However, you still ideally don't want to have Office of Civil Rights knocking on your door and saying, hey, we've had a complaint. I've had customers who have had this, hospitals who have had these knocks on their doors and complaints from the Office of Civil Rights. And as it turns out, the organization, the hospital, was able to show that they made a very good effort in all cases to have interpreting services available for the patient. They documented all of these efforts that they made, and they were told, they were not found to be in non-compliance, but at the time, this particular hospital didn't have a very good backup system in place. And that is what OCR said. In this particular case, they did not find them in non-compliance, but they said, we need you to have a backup. So in other words, if they were to come back and have a complaint and they still didn't have something in place such as that, after having been told, perhaps the judgment of OCR would be different. But again, they took into consideration a lot of different elements in this particular case. It still wasn't pleasant for the hospital. It wasn't pleasant, of course, ever, to have to investigate a complaint after it happens. So again, ideally you'll have an opportunity to talk to OCR first. So let's look at some real-world examples of how Title VI is put into place with healthcare providers. So these are actual examples of things that I've heard hospitals and healthcare organizations say. The first one, the patient speaks English good enough. We don't need an interpreter. So to review what I was describing earlier, this is not not the provider's decision. The ability to speak conversational English is not sufficient for a medical setting. So, what about the ability to read English? What about the ability to understand medical terminology? What about the fact that somebody is, stressed out and sick? What about understanding consent forms? What about the family members that may or may not understand English well enough? So again, it's not the provider's decision. It is the patient's decision whether or not they have an interpreter available. And let me also point out that they may need to be offered an interpreter at more than one point of access. So, for example, perhaps they come into the emergency room, or let's say they come into, let's change this example a little. Let's say they go to an outpatient visit. Somebody's going to get their blood pressure checked, and they feel very comfortable to go to their doctor and get their blood pressure checked. They feel comfortable speaking English. They've been to this provider before. They understand what to do, no problem. They have a good communication. Well, they find out that their blood pressure is through the roof, and they've also been having headaches, and now the provider wants to admit this person for observation. Now this individual may need to be offered an interpreter again, because now the situation has become more complex. So keep in mind that just because somebody may not need an interpreter at one point doesn't mean that they might not need an interpreter at another point. Perhaps now surgery is going to be required. Now maybe that person needs an interpreter. So consider that interpreting may need to be offered at more than one access point. You didn't bring an interpreter? Well, you'll need to reschedule your appointment, and by the way, bring an interpreter with you next time. This is not allowed by OCR. This is clear discrimination, and the patient is neither responsible for finding their interpreter nor for paying for an interpreter. Many providers might say, well, we're not a Medicaid provider, so we don't need to comply with Title VI. The other questions would be then, do they receive any other federal financial assistance? Do they get a grant? Do they provide Medicare? Does the provider have a contract with a covered entity? So again, these things are all part of what OCR is going to be looking at. And that contractual obligation is something that a lot of providers aren't familiar with. Even the hospitals aren't always familiar with that, with the fact that they can require compliance by their contracting physicians. Now, sometimes providers will say, well, okay, yeah, we contract with the hospital, so now hospital, we want you to send the interpreter to us. And that's not necessarily the case. That's not, Office of Civil Rights requires actually that the provider do that, you know, as long as they're not an affiliated or they're part of the hospital, which most physicians aren't. Most physicians are contractors and not staff. So that would have to be an arrangement really between the hospital and the practice as to whether or not those the hospital would provide the interpreters, but typically they don't. They're not required to. The patient has private insurance. Well, this Title VI compliance is not dependent on whether or not the LEP is a recipient of federal financial assistance. So if patients have private insurance, but the provider is a Medicaid or a Medicare provider, for example, or receives grant money, then it doesn't matter whether the patient himself or herself receives those funding, that type of coverage. It's whether or not the entity receives that kind of coverage. We only have one Spanish-speaking patient, so we don't need language services. As I was mentioning before, it doesn't matter what the, you know, how many people are walking through the door. It matters about the demographic potential of the service area. So, and that to me seems so intuitive, but many providers don't see it that way, especially if they're monolingual. They just don't realize that they're preventing access by not having language services. They don't realize that people aren't coming through their door because they can't communicate. So it's really important that people understand that. And in fact, time and time again, it's shown that once providers do begin to provide language access, they see that these individuals do exist and that they do need their services. Be sure to cancel within 24 hours of your appointment to avoid being charged for the interpreter. The question here is this equal treatment? If you don't have a reason for other patients to have to cancel within 24 hours of an appointment, then you cannot require this of your LEPs either. Our contracted interpreting agency doesn't have a blank interpreter available right now. In situations in which this occurs, the organization must document, or the provider must document, that an attempt was made to provide the service. This is what OCR is going to be looking at if there's a complaint. They're going to be looking at not only whether you have a contracting agency, but they're going to look to see specifically that you requested an interpreter and that the interpreter was not available. And again, as I mentioned, OCR is going to expect the healthcare organization to have a backup plan, meaning more than one agency, or if they have staff interpreters, they're going to expect them to have a contracting agency as backup. They're going to expect them to have over the phone or VRI, perhaps a combination of all of these. Similar situation, our over the phone or video interpreting agency doesn't have an ex-interpreter available right now. It can happen. You know, as much as we try, there are languages of limited diffusion that sometimes interpreters just aren't available. And, you know, at any moment, need or demand can exceed capacity. This is just the reality of language services. Again, it's very important that documentation show that an attempt was made to provide the interpreting service. So what if the interpreter says, you know, the patient's husband speaks fluent English, so the doctor told me to leave? I hear this a lot. What do? Well, the provider told me to leave. The provider told me I wasn't needed. I got to the assignment and then I found out I didn't need to be there. They told me not to be there. Well, again, to review, number one is to document this very clearly. This has to be documented. I also suggest, and Office of Civil Rights suggests, that organizations have a waiver of liability, that the patient and the person who is going to interpret for the patient sign to show that the individual is competent and that they are waiving their rights to a competent, trained interpreter. I'd also ask if the organization has a policy that might require the interpreter to stay in the room. So this may be something, particularly if you're a freelance interpreter, you may want to know if the organizations that you're going to perhaps require you to stay, even if the patient chooses to have a family member interpret, or if the provider says, no, this person, a lot of times the physicians don't know always the policies about language services. So they could say, oh, we don't need you anymore, but the hospital may have a policy that says you have to stay. So the healthcare provider, keep in mind, it has the burden of providing adequate care, and therefore the provider also has a right to the professional interpreter. So even if the patient says, oh, I don't need the interpreter, so I want my daughter to interpret for me. She's an interpreter. She's a professional interpreter. I want her to interpret. The provider doesn't know what that person's qualifications are. They are under no contract with that individual in case something happens or happens to go wrong. And they have the right to have an interpreter, their professional interpreter, in the room. So let's review. I've got some poll questions here, and I do see that people have been sending in some questions. Thank you very much. I'm going to do my best to review those and answer some of those questions before the end of our time here today. We've got plenty of time for questions and answers. But I'm going to throw out here our first poll question. So the first question is, who has to comply with Title VI? Patients, covered entities, or only hospitals? I'll give everybody a couple of minutes to click on their answer. This is a pretty easy one, I hope. And while you're answering, I'm going to be browsing through the questions here that you've posted. Just a couple more seconds here, and it looks like almost everybody has voted. So I'm going to go ahead and close this poll. So we had 94% of you said that covered entities are the ones who are responsible for complying with Title VI, and that is the correct answer. Patients are not responsible for complying, and not only hospitals are responsible for complying. So this is important to review, just to make sure that everybody is very clear. A covered entity can be a hospital, it can be a public health department, it can be a private practice, it can be a mental health organization, it can be any organization that's providing healthcare services. And in fact, this is not only limited to healthcare. We're focusing on medical interpreting right now, but this also happens to be relevant for example, the court systems and education. All right, let's go to the next poll question. What services need to be provided in order to comply with Title VI? You may mark all that apply. And again, this should be an easy one. Okay, I think we're ready to go ahead and close that one. And the answer is that all of these elements have to be provided. Interpreting, translation, providing notice to the LEPs of their right to language access, free of charge, staff training, and program monitoring. And I will answer some questions. I see that some questions have come through, in particular about translation and about staff training. So I'm going to go ahead and answer those right now. One of the questions was, well, how do interpreters know, number one, whether information has been translated, and secondly, whether or not it should be translated? That's a good question. What I would say is that it can be a little bit tricky, and it's not necessarily your responsibility to know. But again, I feel that as an advocate, as a patient advocate, you can make a suggestion that perhaps an organization would want to have a particular document translated. So to me, at the most basic and most logical, it would be consent forms. If you are asked to go over a consent form for any patient, any type of consent form, I would say that should be translated. Now, as I mentioned, the language that it gets translated into could depend on the population size of the language group that this organization may service. So, for example, if you've got 13% Spanish-speaking population in your community, that's clearly over 10%. Let's say in a city or a county, that means that pretty much any healthcare organization that receives federal financial assistance should have their vital documents translated into Spanish. What if you have a 1% population of Burmese? That does not necessarily mean that the healthcare organization has to have these vital documents translated into Burmese. What it does mean, however, is that all your Burmese interpreters should be very well competent to provide site translation, because that will help the providers to be in compliance. So I think that this is an opportunity as well to explain to providers the importance of having materials translated for patient safety reasons. So explaining to them that by having the materials, the vital documents translated, it's assuring that it's gone through a multi-step process by competent individuals, and that every patient is receiving the same information every time. So if we help them to understand what site translation is, they can begin to understand that there's going to be variability from one interpreter to the next every time site translation occurs of a document. The other thing that I like to tell providers is that if you are paying for an interpreter to do a site translation of a document every single time a patient needs this form, it's probably going to be a heck of a lot more expensive than having the form translated and available. So that's because, you know, cost is typically a consideration, but if they're paying for an interpreter's time to be going over that every single time, typically a one-time translation is going to cost less. Now, having said that, a lot of healthcare organizations are going to have to prioritize their needs. So you may go in and you may find that things are not translated. And it's simply because they haven't gotten to it yet, and you know they've been working on getting other things translated, and they just have to prioritize. So again, I think it's just nice to gently explain, you know, or suggest that a particular document get translated. And it's always nice to ask too. You can always ask as an interpreter, by any chance, you know, is this available in such and such language? It would be a lot easier for me and a lot easier for the patient if this is available in their language. The other question was about staff training and if there are resources for staff training about effective utilization of interpreters. I don't have a list to give you right now, but yes, the answer is yes. There are programs that offer both guidance and training for staff in how to effectively utilize interpreters. But it's not just about utilization of interpreters. It's really making sure that staff understand Title VI. Number one, they need to understand the mandates, such as not only Title VI, but also how HIPAA applies to language access. They need to understand how the Americans with Disabilities Act applies to language access for individuals who are deaf and hard of hearing. So that's one thing, helping them to understand mandates, helping them to understand what language services are available to them and how to use them. Again, it doesn't help if only the managers know how to access language services. If there's one person in administration that knows that there's a contract and has the phone number for over-the-phone services and has the language access code, that's not going to be helpful if a nurse on the floor is the one needing that service and doesn't know how to access it. So staff need to know that language services are available in the organization, and they need to know how to access them and what any other policies or parameters there are around that. And then again, making sure that staff know how to use interpreters. I always think it's nice to make sure that staff know about interpreter codes of ethics and standards of practice, that they understand what competency might be required of interpreters within a certain organization, because a lot of providers still don't know that. They're unclear. They're learning more and more, but they're still unclear about what that means. And they don't know that many don't know that there's a national certification. They don't know that some states are moving towards certification. So there's just still a learning curve out there. And so as interpreters, we have a great opportunity to help people understand these things. Like I said, every encounter is an opportunity for education. So next question, next poll question. Who pays for language services? Is it the patient, the insurance company, the covered entity, or the Office of Civil Rights? Okay, it's been a minute. Looks like most of you have voted. So we've got 85% said the covered entity pays for language services, and that's correct. So everybody seems to have gotten the message that the patient does not pay for this. Now, some of you responded that insurance companies pay for that. There is the issue of workers' compensation insurance, and so there are some situations in which workers' compensation will cover interpreting services. But as far as the Title VI compliance, that's the covered entity. And Office of Civil Rights does not pay for these services. So this, again, it is really kind of a thorn in the sides of many providers that this is an unfunded mandate. But that's also something that many of us in the language industry are trying to address and show that by having interpreters, and there's some recent research out that shows that actually having interpreters reduces costs to the organization. And in fact, there are a couple of states that are starting to provide reimbursement, whether through Medicaid or Medicare. So that's starting to happen little by little. And I think that the fact that we have national certification and some states have state certification, we're going to see more and more of this. All right, last question. Should be an easy one. Which organization investigates complaints? The American Hospital Association, the Joint Commission, Office of Civil Rights, or the American Civil Liberties Union? Okie doke. We've hit on a minute there. It looks like most people have voted. So close to 80% of you said that the Office of Civil Rights is the organization that investigates complaints, and that is the correct answer. Now, quite a few of you answered the Joint Commission, so let me explain about that. The Joint Commission does certify hospitals and other healthcare organizations, previously called JACO, now called Joint Commission, and they go in and do their reviews, and they have begun in maybe the past 10 years or so, and gradually more and more, they have begun looking at language access issues. So it is correct that Joint Commission looks at language access and will consider both the qualifications of the interpreters, for example, the ability of staff to access the language services, the policies and procedures that a healthcare organization may have, but they are not the ones who are responsible for investigating complaints. That goes to the Office of Civil Rights. So just to remind everyone, the complaint process is driven by a written complaint that can be made by any individual. So it can be somebody who works for the healthcare organization. It can be somebody who doesn't. It can be the patient. That doesn't need to be the patient. It can be anyone who observes that this discrimination perhaps is occurring. Okay, so we're going to go ahead and jump to questions. We've got some more time here for questions, about 10 more minutes. And I'm going to try to read through these the best I can and answer as many as I can. So one of the questions was saying that they were told, and one of the interpreters on the line was told, that it is the provider's choice to decide whether or not an interpreter is needed. So again, I'm going to say that is not, according to the Office of Civil Rights, the patient's right. According to OCR, it is the patient's right to decide whether or not they need an interpreter. It's possible that a healthcare organization has a policy that says that the provider is going to be the one who decides, or they may have a practice that says that the provider can decide. But in fact, it is the patient that has the right to decide whether or not they need an interpreter. And as I said, they have a right to know at any point in time that they can request an interpreter. So if they walk in the door and they're feeling fine and then things start to get complex, they have a right to request an interpreter. And I think it's important, for providers to understand, they just don't always understand language itself. So the understanding of whether or not interpreting services are needed is dependent on understanding how language works and how language learning works. And somebody can be fluent in English, but if they want an interpreter because they think they might miss something, they actually have that right. OCR does not deny them that right. There was a question about what happens if a healthcare organization has the opportunity for face-to-face interpreting and also uses phone services but denies face-to-face interpreting to LEPs. This is something that I'm familiar with happening in a number of organizations, that the face-to-face or the on-site interpreters may be available, whether by staff or by contractors, but that the organizations are choosing to use exclusively over-the-phone interpreters. I'm not familiar with any situations in which the Office of Civil Rights says that this is any type of a violation or that they don't allow this. And again, I would encourage the organization itself to double check and to talk to OCR and to see if their policies and practices are basically kosher with OCR. Keep in mind that basically what OCR wants is meaningful access. So if over-the-phone interpreting or if video remote interpreting is providing meaningful access, that's what they're looking for. Now, if through the over-the-phone interpreting service, an LEP is not able to get site translation of a consent form, that's not meaningful access. So therein would be a dilemma. So it really depends, I think, on the organization. I talked about those elements that they're going to be looking at as far as compliance, and looking at the scope of services, looking at the goals of the program, looking at the financial resources. So there's a lot of things that they're looking at. So it's not possible to say that just because an organization is denying face-to-face that's wrong. There may be reasons that it's okay. But again, the key thing is meaningful access. While I've been talking, I put up the resources page for you. This is really the main resource that you have to go to if you want to know about more details about Title VI. The guidance, it shows there under LEP resources and tools, the guidance to federal financial assistance recipients, yada, 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 yada. It's a big, huge document, very, very, very detailed. I know a couple of you have written in and said that you're interested in the primer. I will be happy to send that to you. I'll give you my contact information in just a moment, and please send me an email and I'll be happy to send that to you. I basically simply extracted information from that large document and pulled out the nuts and bolts of the guidance, just so that it's easier to digest, and it's something that's nice and easy for providers to look at too. So there was a question about, saying that interpreters, a lot of interpreters, maybe many of you are very familiar already with Title VI. You may be very familiar with what it means to LEPs and what their rights are, but how do you communicate that to the providers? Is it your responsibility to do that? And how do you go about that when when providers, if providers aren't paying attention and they're the ones that are going to need to be in compliance, then what is the role of the interpreter? Again, I would say I think this is an advocacy role for the interpreter. I think there are many times that you're going to have to repeat this information over and over and over and over again. So I do think it's very important for interpreters to be able to answer questions. I do think it's very important, some of those questions that I put, those real world examples, I think that it's very important for interpreters to be able to handle those kinds of questions, so that, for example, if you arrive at an assignment and you're told to go home, you need to know how to explain to somebody that, whether to the patient or to the provider, that they may want to keep you around in order to be in compliance with a federal mandate for language access. If you are a manager of interpreting services, you may need to be able to explain this to the individuals that are on the front lines that say that they can get by without an interpreter. You may need to explain to that doctor who thinks he knows enough Spanish that he doesn't need an interpreter that yes, he needs an interpreter, because that if he's not competent in the language, that is not providing meaningful access. You may need to advocate for staff training and help organizations know that it's not just a matter of having that contract for interpreting, that they need to help their staff understand how to use the service. I can't tell you how many customers we have that, so many of their staff just still don't even know that they need to even have an interpreter, number one, or how to call for an interpreter. So again, it doesn't matter if we talk to administrators and people have contracts, that everybody needs to know, at any point of access, individuals need to know how to use the interpreting services. So I think that interpreters have a tremendous opportunity for educating a great number of people about this. And again, we also have an opportunity to educate patients because most of the time they don't know that this service is available to them. Or they may know that it's available at a hospital, but they may not know that it's available to them at a public health department or some other clinic that they may need to go to, let's say a specialty clinic. So you have an opportunity within your communities, whether it's writing little columns for a newspaper, whether it's talking to people at your faith-based organizations, giving a presentation about Title VI, or hosting a presentation about Title VI in the language of your community, helping people to understand this and understand what their rights are for meaningful access. I think that's also very important. I think I have time for maybe one more question here. Give me just a minute to go through here. And my contact information is here as well. So there's a question here about what happens if the patient says that they don't need an interpreter because the doctor can speak their language. Should an interpreter stick around for the appointment? And my answer is absolutely, because the doctor isn't probably the only one interacting with that patient. I have a customer here in California that's a perfect example of that. They have a number of Chinese-speaking patients because they have a Chinese-speaking physician, a Mandarin-speaking physician. So they have a number of Mandarin-speaking patients. But those patients can't communicate necessarily well with the front desk staff, the nurses, the medical assistants, and after hours, if they need to call, and if their doctor, if their Mandarin-speaking physician isn't the one that's on call that particular evening, and another physician is covering that, they need to still have meaningful access. They still need to be able to communicate with the provider. So my answer is that if they say that they can speak with the doctor, that's fine, but there are a whole lot of other people that need to be communicated with, and the other providers, the nurses, the dietitians, the social workers, the medical assistants, whoever it may be, everybody in that healthcare organization, whether it's a private practice or a hospital or a health department, they all have the right on the provider side to your services as an interpreter to help assure that they're providing the right care to the patients. So it doesn't matter if just one staff person speaks the language. It really needs, there's so many people interacting with an individual. I hope that you've enjoyed this webinar. I'm going to pass this back to Jose, who is going to make some wrap-up comments. But just let me say again, I've enjoyed very much presenting today on this topic. I think it's so important. I appreciate your questions. I'm sorry if I couldn't get to everybody's question, but certainly I'm happy to reply to emails. And you've got my contact information here. I'm happy to send out the primers. And just so you know as well, this webinar, we are planning to post a recording of this webinar to the CHIA website. I can't say how soon that's going to happen yet, but we will be planning to do that for those individuals who want to review the information, or if you know of anybody else who could benefit from this information. So thank you again, and Jose, I'm going to pass it over to you.
Thank you, Michelle, and thank you to Voices Academy for hosting today's webinar. That was wonderful.